Okay, it's 3 o'clock. I think we're, according to my clock, so I think we are ready to begin. Nadine and Erica.
Thank you, Bobby. I want to welcome everyone to another meeting of the Community Vaccine Advisory Committee. And I'm Dr. Nadine Burke-Harris, California Surgeon General. Grateful to be co-chairing this meeting with our state epidemiologist, Dr. Erica Pan. We have lots to accomplish in today's meeting, so I'm just going to go ahead and dive into it and ask Bobby if you can go ahead and start by reviewing our meeting processes and our public comment, and then we'll dive into opening comments from the chairs.
Yes, thank you so much. So just as a reminder to everyone, both the members of the Community Vaccine Advisory Committee and members of the public, our meetings are very interactive. We hope that the members of the committee will keep their cameras on and stay on mute until you're ready to speak. And also, I think everyone's learned how to use the hand raise icon. So we love when you're able to do that, and also to ask comments and ask questions and make comments in the chat. As we have in all of our previous meetings, we're lucky to have Katie Sales and Vicki Kennedy here as our ASL interpreters, and we also have closed captioning for our members and the public. The public is in listen-only mode, both in English and in Spanish on the telephone, and also viewing through the live stream channel that we have on YouTube. If you have any technical difficulties during the meeting, please put those in the chat, and we'll see if we can help resolve those for you as quickly as possible. So going on to the public comment, all of the public comment was sent out in its entirety to members of the Community Vaccine Committee on Tuesday morning. The public comment covers the period March 16th through April 12th. 112 individuals and organizations submitted public comment during this period. And I'll review that very quickly for you. I know you've all had a chance to look at it. 69 members of the public wrote to encourage the California Department of Corrections and Rehabilitation to reduce incarceration in state prisons to below 50% capacity and prioritize vaccinations for staff and inmates. One person wrote that we needed to improve public messaging and communications all over the state about where to get vaccines. 27 people wrote about getting higher up on the prioritization list, either for their occupations or for their medical conditions. And that included utility workers, ordained clergy, mail carriers, parents of care and caregivers of children with CCS eligible conditions who are not connected to regional centers, single parents or solo caregivers of children, people with type 1 diabetes, people with cystic fibrosis, people with sleep apnea, people with BMI under 40, people living with HIV and AIDS, people with lupus, people with schizophrenia, and people who travel internationally. One individual wrote asking that the California Department of Public Health allow nuclear medicine technologists to be vaccinators. One individual wrote requesting the need for in-home vaccinations for the elderly. Two people wrote asking that we address equity more effectively. And one person wrote in asking that masks be optional. And that covers the public comment for this period. Thank you.
Thank you so much, Bobby. And I'll start by making just a few opening comments before I turn it over to my co-chair, Dr. Erica Pan. As usual, I'll start the meeting by anchoring and grounding our work with the values that guide us in doing this work, which are the values of safety, equity, and transparency. And I repeat that at every meeting, but it feels important and all the more important at this meeting, considering all of the events that have transpired since our last meeting on March 17th. Most recently, the pause on the use of the Johnson & Johnson vaccine nationally to take time to investigate some safety questions, and also at the same time a recognition that this process, right, this process by which we are taking the pause and looking into this is exactly how our vaccine surveillance system was designed to work. And we heard in the public comments a question about equity. A lot has happened on the equity front since our last meeting. We're really pleased to have an update on that today. And so as we look ahead to our agenda for today, first we'll have an update from Dr. Pon about our vaccine supply, eligibility for vaccines, and guidelines for vaccine verification. We'll get an update about that Johnson & Johnson COVID vaccine pause and the ACIP recommendations. As many of you know, the CDC's ACIP met today. In fact, just before this meeting, many of us were tuned in. Many of you, I know, were tuned into that process. And so we'll hear an update on that. And we have the extraordinary fortune of getting an update from Dr. Grace Lee, who is a member of our Western State Scientific Safety Review Work Group and also a member of the ACIP. And then following that, we will hear an update on achieving and monitoring equity. And that's a conversation I'm really looking forward to, because the state, as well as our partners at Blue Shield, have been really working very, very diligently on equity. And we want to not only present an update to you all on that, but also to, of course, hear your feedback and comments so that we can continue to improve the process. And with that, I will go ahead and turn it over to Dr. Pon for for opening remarks and comments.
Great. Thank you so much, Nadine, and good afternoon, everyone. I just wanted to start by kind of thanking all of you. And, often I like to start with a little bit of reflection. And last week was Public Health Week, and, just continuing to reflect on how far we've come as a state and where we're going. And we've accomplished so much together as a state to respond to this pandemic and to this very challenging virus. And we know we're all going to be stronger on the other side of it. And we're absolutely seeing that light at the end of the tunnel get brighter. And this week, actually, we had our first week with no counties staying in the purple tier in our Blueprint for a Safer Economy. And as you know, the other big announcement since we last met was moving forward and thinking about beyond our blueprint and thinking around that mid-June, we can be really in a much better place if we can use all these tools that we have to get to immunity. But also just noting and acknowledging as we look at that light at the end of that tunnel, that our tunnel can have twists and turns. I continue to be humbled by, again, this virus and this pandemic and this situation. And we're going to have these narrower areas of the tunnel and twists and turns and some wider areas where we make a ton of progress. But we're continuing to, again, move our way through it. And again, using all the tools that we have, and we're continuing to gain more tools. It's just incredible, again, that we have vaccines and how quickly they were developed to be here, and that we have two widely available vaccines in our midst too while we have this pause. So we're going to continue to move forward. We're going to get there faster and more resilient if we do it together. And more united. So I'm just so incredibly grateful for this committee and all of your input, and all of my colleagues in public health and all team members and colleagues across state agencies who continue to march forward together. So with that, I'll start with my overview of epidemiology. Start with our slides. You can do the next one now. So as I often start, just kind of giving you a quick snapshot of some of our epidemiology. So we are at 3.6 million cases in California to date, and our case rate though is quite low. So we're at about 4.7 cases per 100,000 per day statewide. And our deaths continue to decrease as well. Our testing has decreased a little bit, but our testing positivity, which is another helpful marker of how we're doing as far as disease transmission, have remained less than 2% for at least a couple weeks. So we hit our lowest mark a day or so ago at 1.5%. I think it's, bounced around a little bit. And hugely, and we'll talk more about this, of course, over 23 million doses of vaccine administered. Next slide. And so this is kind of, again, talking about as I first started, where we've been and where we're headed. You can see our first bump here again in July and our huge winter surge. And we had this nice decline here. And you can see we've been nice and flat and declining gradually since the end of February. And we continue to stay stable, although I will say the other kind of twist in our tunnel lately is that we are starting to see some slight increases in our cases and actually some slight increases in our new admissions as well. So I think just, to take that moment as well to remind everyone that there are lots of tools and we need to continue to get people vaccinated, but our masks are working and can work if everyone continues to use those, and our physical distancing, all of these important measures we've been talking about all along. These are what are going to help get us through this and to that other side. Next slide. So this is some of our great news too, as far as how far we've come. So you all have seen this dashboard, hopefully on our website, and we're continuing to work on improving this. But you can see again, and actually the latest since this slide was created is that 23.7 million doses have been administered to date. And as you can see highlighted over here on the right, I think we've actually hit 9 million individuals who are fully vaccinated. So, over a quarter of our people eligible in the state are fully vaccinated and protected, which is really great. And then of our over 65, we have over 3.6 million fully vaccinated and over 57% of our over 65. And then if you look kind of at that together, as far as our partially vaccinated plus fully vaccinated, we're getting really close to having half of our eligible people with at least one dose of vaccine in California, which is just incredibly exciting. I think many people point to looking at the Israel experience that when you get to kind of between that 40 to 60% is when you start to see some really dramatic impact. So continue to keep our eye on that. Although, again, as I mentioned, we're starting to see some mild increases, and what we're seeing in other states is some surges, and some of that is happening with variants such as the UK variant, which is creeping up a little bit in California as well. So we really need to keep up all of our mitigation efforts. Next slide. And then again, this is such a nice illustration of, again, the ramp up and how, we started with our lower amounts in the middle of our surge in the middle of the holidays, and here we are. We're usually averaging over 300,000 doses of vaccine a day, and continuing to plow ahead with that. So that's been, incredibly encouraging as well to see that we continue to ramp up over time. Next slide. And then I know we're going to focus a lot later on in the agenda as well on our equity, but this is kind of, again, from our website. You can see the graph comparing how we're doing with our health equity metric. So there's different ways we've been looking at this, and actually different ways we're going to be posting probably very soon as well. But looking at our quartiles. So in quartile 1, we have 1.4 million, or about 17.6% partially vaccinated, and then over 22% who are fully vaccinated, in contrast to quartile 4. And there's another graphic on our website, and that's going to be covered later, where you can see the gap has been decreasing over time, but we still have work to do to actually reach equity. We're getting closer to equality, but we need to move to equity, where we're seeing a disproportionate number of people vaccinated in our quartile 1. But compared to where we started, there's also been a lot of progress in this area. Next slide. So, and then, of course, top of mind is the pause. But as far as our overall supply, we've been currently receiving around 2 million doses a week. Some of that, of course, is allocated to California. And then there's a lot of federal doses that come into California as well. The allocation, is supposed to be increasing in the near future. It is relatively flat for the next 3 weeks again. And of course, this is impacted by a couple of different issues that have come up with the Johnson & Johnson. So both the manufacturing issues and then this pause over the last day. But again, we have 2 other vaccines that are continuing to increase in their production, the Pfizer and Moderna. And then people have been asking sort of what proportion of our supply has been Johnson & Johnson. To date, as far as historically, Johnson & Johnson is about less than 5% of vaccines given to date. And then here in California, just for this week, Johnson & Johnson was about 4% of our allocation, and probably looking at our numbers, including federal and state allocations, around 6 to 7% over time has been allocated to Johnson & Johnson. And again, we have the opportunity to have Dr. Grace Lee join us later, who not only is on the ACIP committee, but the co-chair of the vaccine safety technical subgroup of that committee. So it's really an honor and a pleasure that she'll be able to give us the latest updates from the ACIP discussion today. Next slide. And I think we've all thought and talked a lot about eligibility and priorities over time and who can be vaccinated. As you know, as of April 1st, we were individuals 50 years of age and older were eligible. And then starting tomorrow, every Californian 16 years of age or older is eligible to be vaccinated here in California. And as you also probably know, I think over half of the jurisdictions had actually already started moving to every Californian 16 years of age or older. But statewide, that will be the eligibility starting tomorrow. Next slide. And then as far as verification, this is coming up in a lot of different ways. So I'll sort of, before I walk through this, I'll just tell you, and I'm sure you're also hearing, there are a lot of conversations happening at the federal level, and certainly we're staying in tune with that at the state level as well, around vaccine verification and what are the best ways to do that? How can we make it more convenient? What are some standards we can apply to make sure that, that you can do verification, but that people can have access to the verification, and that we do this in an equitable and ethical way. So again, we're working on this diligently as a state, especially these digital apps that many dozens of businesses have started to develop these. They're being piloted in certain areas. In the short term, as far as vaccine verification, since we already have, again, over 9 million people fully vaccinated, as far as proof of verification, which is starting to come up in other sectors and venues, people can use their vaccination card, so their CDC card that they got when they got that vaccination, a photo of that card as a separate document, or it can be a photo on an electronic device like a smartphone, or some sort of documentation from a healthcare provider for people that get their vaccine at their regular clinics. So again, I think there's going to be more to come on this as far as digital apps and things like that will make it more convenient. But this is kind of what we're putting into kind of our addendums to the blueprint sector for now, is ways people can verify their vaccination status. Next slide. And this becomes relevant because of this. So we just added within the last few days as well, kind of addendum to the blueprint here. And while we're in transition over the next couple months of our blueprint, and as we're moving our counties through the blueprint, we have actually, we have some what we're calling capacity bonuses for allowing for more people to be in shared spaces and be more protected. So that actually entails, if you have people that are fully vaccinated, and as you all know, the CDC, and we're posting, very, very soon as well, our kind of aligned guidance around if people are fully vaccinated, they can share space with each other, they can be indoors, you can be visiting with someone else in their household if all of you are fully vaccinated without distancing and without masks. There's one sort of caveat there too, that if you have low risk people in one of the households that are not vaccinated, and really the people in mind for that are young children who are not yet eligible to be vaccinated, it is okay to have some mixing. And this is really geared towards grandparents, which I can say personally, I've seen a lot of joy from both my kids and my parents and in-laws being able to see each other and hug each other now that all the adults are fully vaccinated. But as far as this, just briefly, In the orange tier and the yellow tier, we're adding these capacity bonuses so that in certain sectors, the capacity can be increased by an additional 50% for a maximum of 50% total venue capacity if everyone shows some verification of vaccination or testing negative within the last 72 hours. And then similarly in the yellow tier, the capacity can be increased by an additional 50% up to a max of 75%. And then there are ways that businesses can have, vaccinated only sections, or they can have a vaccine if they have an event that is vaccinated only, they don't have to use physical distancing, which actually allows them to have more guests or more attendees. Next slide. And the other thing that is also actually really exciting and that it got announced last week as well, that we are actively starting to plan for, and I think will be a great topic for next month's agenda to talk and get more of your input, is Pfizer has applied to expand their use in adolescents 12 to 15 years of age. And to remind you, the one vaccine of the three that have EUAs that allows 16 to 18-year-olds is Pfizer. So they're already authorized to do 16 to 18-year-olds, whereas the other two are 18 and up, and they've just applied for the 12 to 15-year-olds. So we're waiting to see what the FDA approval is for that. Some of the people are anticipating in about a month or so there might be a response on this, but they had really encouraging data in their phase 3 trials. So this is another really exciting development that we will get another proportion of our population vaccinated very soon. We estimate this is around 2.6 million Californians are in that 12 to 15 years of age. So again, a lot of good work happening as we speak on starting to plan for that and think through that, and we'd love to talk to you more about that at the next meeting as well. Next slide. So I think I will pause there, and let's see, I know we might have to move around our agenda a little bit just based on how the ACIP and other things have been going today. So I'll let Bobby explain our rearrangement.
Yeah, I think we'll stop now if it's okay, both Nadine and Erica, and have some comments and questions from the committee members. It is possible, as Erica just said, that depending on Dr. Lee's timing, that we may have to shift the next two agenda items around to accommodate her schedule, but we haven't heard anything yet that she won't be able to make it as planned. So maybe we can take the slides down and see everyone. And if you'd like to make a comment or ask a question, please use your hand raise icon. I think everybody knows where that is, and let's get to it.
And actually, quickly, Bobby, while you're looking on who to call on, I am seeing one of the first questions about the other parts of pediatric vaccination, the 0 to 12-year-olds. So there are some trials happening now in the 0 to 12-year-olds, and some of the kind of projections or speculation I've seen are that maybe by the end of this calendar year or early 2022 is when we might be able to anticipate. But I'm sure that will be an evolving timeline as well. But that's kind of what we're anticipating. The other pleasant surprises have often been things have been sooner. I didn't anticipate the teen application would happen so early, so maybe that will be earlier than we hope, but that's kind of the latest projections that I've heard of on that.
Great, thank you, Erica. Okay, let's start with Mitch. Don't forget to introduce yourself, Mitch.
Yes, Mitch Steiger with the California Labor Federation. And these are, really encouraging numbers. It's really great to see all of this. I just had a quick question about tracking those who've been vaccinated to see how well those percentages are still holding of, this one's 95% effective against this, that one's 66% effective against that. Are we, when someone comes in with a new case, is the system able to say, oh, you were vaccinated, so we're keeping track of how many people that have been vaccinated are still getting it to make sure that those numbers are still accurate, roughly, with all the variants floating around out there?
So is your question, as we're getting new cases of disease, if we're finding out if they've been vaccinated or not, to look for resistance to vaccine, or are you asking more about tracking just in general who's been vaccinated?
I think more the first one. So when folks come in with a new case, and is whoever they take person, the treating physician, saying, have you been vaccinated, so that we can kind of merge that in so that we can say, oh yeah, of all the, looking at the numbers and being able to somehow figure out, we've given out this many vaccines, this many people have come back with new cases within that cohort of people who've been vaccinated. So we know that X really small number of people who've been vaccinated are still able to get the virus?
Yeah, no, great question. There's a few parts to that answer. So there was some recent data that the CDC put out, and sort of the technical terminology we talk about is efficacy is in the trials, which are very kind of regulated and scripted. And then there's effectiveness once you're kind of post-market, distribution. And there was some really encouraging data that came out from the CDC very recently about high levels of effectiveness for Pfizer and Moderna. And then your other question about new cases. So yes, absolutely. And I think the other good thing, it's very important to talk to all of you about and to continue to make sure we're communicating to the public is that, these are, again, outstanding, 95% or so effective, but that means that 5%, right, might still get infected. And when you're vaccinating millions of people like this, you are going to have people who are vaccinated who test positive. What's been really interesting, both in that study and then I would say anecdotally, as we're hearing about certain situations at the state level, what we're seeing is that people that are vaccinated have either no symptoms or very mildly infected. And actually some of those that are still getting tested have what we call looking at very low levels of virus, which really suggests they're not going to be infectious to other people. So more and more data is accumulating on that. And then the other project we're working on very aggressively, because again, there are sometimes data challenges, but looking at hospitalizations and really closely monitoring of people who are hospitalized, have they been vaccinated or not? And so there's some data system integration that needs to happen to do that as well, but we're actively working on that as well. Because that, to your point, I think maybe the point you're getting at is we want to know if there's an increase in cases that are not vaccinated. So we're watching that. And then of course the other pairing to that is looking at whole genome sequencing, which actually I didn't touch on. Happy to if people are interested next month. But we have increased the proportion of specimens we're sequencing. It's up to about 7% of the cases we're sequencing to look at variants. And again, we're seeing an increase in the B117 UK variant. It's getting close to 10% of what we're sequencing. And we're trying to get more systematic about what we're sequencing as well, including really aggressive sequencing of hospitalized cases. And specifically, we'll be looking more for intensive care unit cases too, to just make sure we're looking for that.
Thanks, Mitch, for that question. Let's go to Deborah and then we'll go to Anthony.
Okay, I wanted to bring this up.
Don't forget to introduce yourself.
Okay, my name is Deborah Shade. I represent the California School Board Association. And so my question has to do with really talking about our kids in this population now. I'm hearing from very well-educated moms who have extreme concerns about the vaccine and how it affects long-term reproductive health of their daughters. And now with the J&J coming out today with women with blood clots, I just think we're doing a lot of work to get the information out, the correct information, the hesitancy we're seeing in communities. But I think there's a level of hesitancy that you're not aware of. And certainly any parent, anybody who's involved in school districts know there are a lot of parents that have any kind of immunization hesitancy. So I'm hoping maybe next month we can talk about this. I think it's going to be an issue. And, for schools to get open and to get get back to the system that we know of as education, we're going to need that. We're still seeing cases in our pediatric population. So I didn't know if you want to comment on that now, but I certainly would like to get that out there today since we were talking about the 16 and older, because that's one population. But when you get to anything lower than that, it's a whole nother ballgame.
Yeah, I can speak briefly to that. I think really helpful, good point. And I want to acknowledge that, in some ways we're opening up earlier to eligibility because it does seem like, demand is not as high as it was. And so we do need to work really hard on what are those. I do think there's a lot of great work that you've been hearing about and we'll continue to work on as far as the Let's Get to Immunity campaign and other parts about that. And I think, the other grand rounds I just was on yesterday was thinking about, we don't know yet what, we just had this vaccine with us for 6 months, but we do know that we're seeing a lot of long-term impacts of COVID itself and kids amongst that as well. And really that's really the unknown to me. And just looking at that ratio again of we've had over 3.5 million cases and 60,000 deaths, right? And for this one vaccine, we've had almost 7 million doses given and only 6 people with these serious side effects. So it's a really different ratio. And I think we need to continue to think about those benefits and risks. But absolutely, I think those are really important things to keep in mind for the fall, because absolutely you may have seen today as well, I think a big emphasis from the governor today on schools and reopening, and we want to use all of our tools, and vaccination is one of them, but in schools we're going to be really focusing on all the other kind of tools we have for mitigation, so continuing to mask, and really thinking about testing as another tool to use to make sure we can get our kids back in school, because that's so incredibly important.
And I want to jump in and add to that in the fact that, especially now as we are responding to what's happening with Johnson & Johnson, I think that it's really important for us to allow people to answer questions, to ask questions. I think it's important for us to really walk the walk in terms of safety, equity, and transparency. And I think that the immunity, Let's Get to Immunity campaign really reflects that it's okay for people to have questions. It's okay for folks to feel nervous or a little bit anxious. And I see an important part of our role is to provide trusted, rigorous information that people can believe in. And I think that if we continue to do that and continue to walk in that way, over time, it may be that it takes us a little longer, right? But we would rather, from my perspective, I would rather have folks have that level of trust, right? And ultimately get there in a way that feels good and that they can trust in, than feel like we have to be rushing. Because I think one of the pieces that we do want to communicate to the public is that we do take any concerns about safety very, very seriously. And we will pause and we will investigate it, right? So if folks are worried about, so the fact, to Dr. Pond's point, that 6 out of 6.8 million cases were identified, and the CDC and the FDA said, okay, let's pause. And, all of the states have said, okay, let's pause and let's take a deep dive. I hope that it offers at least a model of confidence or a little bit of reassurance that if there is a real concern about reproductive harm, right, or if there's a real concern about safety, right, that we will take it seriously, we will look into it, we will do that deep dive and have a very rigorous scientific assessment before we make any decisions on moving forward. And that's something that I hope that the public is seeing now and can trust in.
Thank you both. Let's go to Anthony and then we'll go to Dr. Chon. Go ahead, Anthony. Don't forget to introduce yourself.
Hi, Anthony Wright from Health Access California. Just again, thanks to everybody at the state and the counties for just a lot of work. And I'm sure that everybody's as happy as I think we are to move from the focus on prioritization to now just promotion, starting tomorrow with just getting people connected and not having to worry about, these various tiers as much. I do think that, and I look forward to these existing and ongoing conversations. I hope that I'd love to always just hear more about the issues of vaccine, this proof of vaccination conversation. Hopefully that is also a short-term conversation as we get to closer to the herd immunity, where we don't need to have those conversations. But, in the meantime, if there's anything else to sort of support that, or hear more about the thinking about what the role of the state is would be helpful. But my main question is just, as we're trying to get the better information, I know that many people have been getting their vaccines through a lot of different ways, some through their health providers, but many not, through, county sites, mass vaccination sites, etc. And so I guess I'm just curious if there is any effort on the back end so that information is getting integrated into people's medical records, or if that is a recommendation that people should be doing on the, individually with their own selves. I know that was an issue with regard to the J&J vaccination, that people, let their, at least I heard some recommendation. I don't know if that is a recommendation that is being provided here in California, that people let their provider know if they have the J&J shot, so that they can be some tracking on this. And I don't know if there's some back end way to do that more automatically than just everybody having to call their doctor. And just curious about if that process is happening, or is it going to be more individual?
Yeah, that's a great question. So I think in general, there's before COVID and before the pandemic, we have a California immunization registry, and then there are a couple other subsets that communicate with the California immunization registry, but are separate. There's a San Joaquin Valley one and the San Diego one. So we've had these, and they're of course most robust as far as children's vaccinations, actually, and they have not been a requirement for all healthcare providers, but many more and more, and pharmacies as well, required to submit their data to that. So that is the sort of state database that we have, that all of these COVID-19 vaccines are being integrated with. On the other side of that, in general, again, previously, even with the California Immunization Registry, there have been increasing work on kind of, along the lines of health information exchanges, and certainly bidirectional exchange with large systems and health electronic health records. I will acknowledge it's another area that data integration is, it's always, I as a non-IT person, am always humbled by how much more complex it is than I realize. And I think some of the really big systems have pretty good interfaces that go back and forth that are bidirectional, and many don't. And many of the certainly small providers might be able to do data entry separately and might be able to look and have access, but it's not integrated into the actual electronic health record. So it does vary by provider, just like our overall health system and electronic health records use is really varied. So I think it's sort of a yes and no. A lot of the large systems, again, do have more exchange, and some don't. And people are not entering, at least my understanding is people are not entering their primary care provider into my turn or when they enroll and get their vaccine. So it's not necessarily listed if they're getting their vaccine at another site.
So just a quick follow-up. I can appreciate that not everybody will have their information automatically sent to their health plan or their medical home, et cetera. But do you as a central place have enough data from enough large systems that you feel that you could identify trends like what identified, that caused the pause for this J&J pause?
So we do have all the data on all the people who have received COVID-19 vaccine, whether it's Pfizer, Moderna, or J&J, are in our sort of central system. How much that's linked to any other medical records about them is a different piece. So I think that is where what we've done, I can quickly outline, more at the state level, but even just in the last 36 hours, we have, once we put out the message to all of the vaccine providers to press pause, we're basically working on clinician alerts that, the CDC has also sent out clinician alerts directly to clinicians to really sort of be on the lookout for this, and some of the messaging around all that. But there is not a seamless integration of electronic health records the way we'd like. So it is going to need to be, but the system that actually picked this up is the vaccine adverse event reporting system, right? And again, now that there's heightened awareness both from providers and just the public in general, and anyone who's received any vaccine should just know in general, that's always a way to report a potential side effect, and then it gets investigated, and it can be very rigorous. And that's how this whole situation was detected.
Thank you, Anthony. Let's go on to Dr. Tan and then to Dr. Wasserman. Don't forget to introduce yourself.
Thank you, Bobby. My name is Hendry Tan, and I'm at UC Davis Health, and I represent the California Medical Association. First of all, I just wanted to say how the situation looks so much better than it did when we first got together, and really want to thank CDPH and the folks here because I know that y'all have been working very hard at it. I want to also, share and underscore Dr. Brooke Harris's comment about the importance of building trust and answering questions, making sure that our patients and clients and community members understand and have their questions answered. I think to extend upon that, it raises an issue that actually some of my students have raised as an issue of concern, and that is that while the J&J vaccine has been so helpful from a public health standpoint, and getting vaccine into arms of hard to reach communities, I think the challenge that we have to really be aware of, cognizant of, is the issue of choice, the issue of informed consent and choice. That for those who are privileged, do those who have privilege have the choice to get Pfizer, Moderna, or J&J? And I worry that for those of us in the community that don't have good access, if the choice is limited to a certain vaccine, and in this case J&J, and what are the implications of that long term if there are differential outcomes associated with the vaccines? I know that in times of scarcity, we need to get as much and whatever we can into the communities, but we're going to make a turn where there will be more plentiful vaccine for many people, but not all people. And so part of what I think we need to consider is how are we going to make sure that as people ask questions, that those questions can translate into their ability to have choice, which should be equitably distributed as well. Thank you.
Yeah, no, I think those are great comments. I think one initial response, and I think someone else brought up other important sort of similar points, that we are lucky. I mean, this has actually been pointed out as well. In the United States, we've had these 3 vaccines, right? And we're pressing pause to take this seriously and investigate. And we are going to have a point. It has been really hard for the last couple of months to not have enough, but we're feeling confident we will have enough, that every person who wants vaccine, and in fact, that was part of the benchmark put forward for mid-June, that every person who's eligible can get access to vaccine. And there has always been that choice. I think it's really important to keep in mind as you're talking about, where different vaccines are offered. But we very much, prior to this pause, have really felt that all 3 vaccines are, outstanding outcomes, equal safety and efficacy. And now we're investigating this particular situation to see if we do feel comfortable or not with moving forward. So I think really important points. And I think, again, we're really fortunate here. And now there are some countries that are not, I think talk about sort of global equity. We're really fortunate that we are going to have choices both as a country and as individuals about vaccines. Whereas I think that's been the challenge in some other countries that are seeing surges again and high mortality and having to make really tough decisions.
Thanks, Dr. Todd. Okay, Dr. Wasserman.
Thank you, Bobby. I'm going to just highlight what I put in the chat room. Number 1, regarding data and specificity of the data. We're showing 9,000 deaths in nursing homes, but if someone is discharged to the hospital and dies in the hospital 2 weeks later, they're not counted. If someone dies in an assisted living in the hospital, or if they were in memory care, we don't know that. If someone lives in a multi-generational household and they're poor, it's not clear. And I think data matters with 60,000 deaths in terms of how we respond, how quickly we respond. I put in the chat box also, I did an op-ed in the San Diego Union Tribune. 70% of deaths of under 65, nearly 70% of those deaths have been in the Latino population. And when we look at what percentage of the Latino population we vaccinated, we have a huge disconnect. And I go back to having served on the National Academy Allocation Committee. we've talked all along about getting the vaccine to people who die from the virus. And I just think that we really need to keep our eye on the ball. I noted we're seeing in some of the states where there's surges that the virus is creeping back into these vulnerable populations. So anyway, I think data though is critical, and I'd love to see really more specific data on the vulnerable populations so we can really hold ourselves accountable for what we're doing in terms of vaccinating those populations. Thank you.
Yeah, thank you. And again, there's a lot of work on both sides of that, in that we have a lot of data that is being validated, because we want to be able to share data that we feel has been looked at. And one of the examples is, as far as looking at race ethnicity, one of the reasons it's taking us a while to get that posted is there's different just sort of coding about multiracial versus specific race, and it looked like we were vaccinating 200% of people that were multiracial. Like, clearly that's not possible. So that's just a specific, very concrete example of why we agree with you. We want to have good data, and we want to get it posted and show it. So there is going to be some updates on sort of based on HPI actually within the next few days. I think the race ethnicity data is taking us longer because of a lot of these nuances that are really important. And we do have an excess deaths, I believe, publication talking about the very thing you're talking about. So you're right, we have to keep our eyes, we have a lot of work to do, which is why we're spending some of our time later today talking about equity and really improving where we are and getting vaccine to the people that need it the most.
I do want to add onto that to your point, there are, I'm really excited that you said that, because in our strategy in terms of operationalizing equity, I think that sometimes folks think that if equity is in the thought bubble when you were deciding your plans, that it is then equitable. So we have a lot of work to do. We have been doing a lot of work in terms of looking at lots of different types of data when we're thinking about operationalizing equity. And I want to, I'm grateful for Dr. Kimberly Good at Blue Shield, who has been a partner in this, in really looking at how do we, as we're doing our implementation, not just look at the data around the outcomes, around who's getting sick, who's being vaccinated, et cetera, but the data for all of the steps in between that allow us to push for and drive towards equity and move the dial and the levers, if you will. And I think that in light of that, I know that we are waiting for Dr. Lee to join us, but it might make sense actually for us to move forward to our conversation about equity so that we can make sure to preserve time for a robust discussion about J&J and also have adequate time for a conversation about equity. So maybe what we can do now is go ahead and switch our order and move forward with hearing from our partners on how we are operationalizing and measuring equity. And in talking about that, I want to again reinforce that equity for us is not just a target, right? It is a system. It is a series of dozens, hundreds, thousands of decisions that we are making on a daily basis to drive towards a North Star and really be very rigorous in how we are implementing and applying that. And I'm really grateful to have Marta Green in California Government Operations Agency, Kimberly Good at Blue Shield, and Peter Long at Blue Shield, who really have been leading this effort and has been a wonderful partner in partnership with our teams at CDPH and driving us towards equity. And with that, I will turn it over to Dr. Good.
All or maybe Marta. I'm not sure if.
Or maybe,
Marta's
okay,
going-
all right, maybe Marta,
Not sure
sorry.
who's going first. No, I think.
I'll go ahead and jump in.
Great.
Let's go to the next slide, please. Okay, I think we've seen this slide in the past, but I'll just do a brief refresher on our 5-point plan for equity. So first, and one of the things I care most about is our allocation strategy. So that's that, I call it the 40-20-20-20, or our geographic, our equal weighting, and then our equity weighting, as I like to call it. And there, we'll talk a little bit more about that on a later slide. Then our network strategy. So this is our focus on those providers that do a really great job of reaching our populations that most need to be vaccinated based on their disproportionate disease burden. We are very close to executing our contract on our transportation vendor, which will also help us reach those most in need of vaccination. Also making allocation adjustments to meet our network providers that are doing a really great job in vaccinating our lowest quartile, or those individuals that reside in the lowest quartile of the Healthy Places Index tracks, and making adjustments based upon performance. And more on this on a later slide as well. And supporting our community partners. So we've already set aside $60 million that our equity providers statewide can apply for to expand access to their clinics. So this is to do bigger clinics, to hire more staff. It could be to provide overtime, to do weekend, evening hours, to be able to reach more populations. We've also done some targeted funding. So 7.6 million to Bay Area counties, another 15 million to organizations in Los Angeles. And we're going to be expanding that program statewide in the coming weeks. Data analytics, we're going to go into a deep dive in that in the coming slides, so I won't bore you with it on this one. And of course, we're continuing to support the state's public education campaign. Next slide, please. So here is a kind of a busy but important graph that shows you, what our network looks like and how we have built a network that right now, today, if we had the supply, could deliver 6 million vaccines to Californians on a weekly basis. And as Dr. Pond mentioned earlier, we've only got about 2 million coming in per week, but we're ready for that supply when it comes. And we're there, we're ready for that scale. And we've been able to very rapidly scale to this level. And as you can tell, we have overall a 99% access based upon our metric, even in the first quartile. And we're continuing to provide additional access points to ensure that all Californians can access vaccine. Next slide, please. So again, this is that equity allocation, and I'll spend a couple minutes here. So first, we get that first dose allocation. So as an example, this week, it's just over 1 million doses. We take off the top anything we need for state populations. So this is for, the California Department of Corrections and Rehabilitation, Department of State Hospitals, any populations that the state is specifically responsible for. So then after we take that off the top, 80% of the remaining vaccine is equally distributed based on the eligible population. And as of tomorrow, as we all know, that's 16 and up. So it's equally distributed based on where the 16 and over population lives. And we take that remaining 20% and we concentrate that in the zip codes, the lowest quartile HPI tracks, because as we know, only 25% of Californians live in those zip codes, but they have seen 40% of the disease burden. So we need to concentrate 40% of those doses where 40% of the disease burden has been. So we're double weighting the amount of vaccine that's in those zip codes. Next slide, please. And here I'm going to start to pass it over to Kimberly, but this is how we then, within those zip codes, concentrate those doses in the right types of providers to reach those populations. Kimberly? Uh-oh, we might be having technical challenges, so I will go ahead and continue on. So as you can see, the current allocation approach is doubling the weight on the zip codes. And in the lowest quartile HPI tracks, as you can see, we've got our federally qualified health centers. So those serve our Medi-Cal population, those populations that reside in the lowest quartile tracks. So as you can see, in quartile 1, 46% of the vaccine administrators are FQHCs. So we're directing the doses to those providers that serve the residents of those tracts. 28% are local providers and medical groups. 12% are those large provider groups. We call these multi-county entities. These are entities like Kaiser, Sutter, and the like. And 15% are pharmacies. And what you see is as you go up the quartiles to more affluent areas, you'll see it more heavily weighted towards pharmacies and much less heavily weighted towards FQHCs. Next slide, please.
Marta, Kimberly's on. I think now she's got her sound.
Right.
There she is.
Yeah,
Thank you.
My mouth was moving, but I understand you weren't hearing anything. So thank you, Marta, and thank you, Dr. Burke-Harris. And first thing I'll do is clarify, I'm not a doctor, but I do get to hang around some really smart ones on this project. And on that previous slide where you saw the diversity of the provider network, that's one of the keys that we want to make sure that we have from a robust and broad range within the network. One of the things that Secretary Richardson made very clear to us as we took on this work is that there are no equity providers. Everyone in the network is an equity provider. Everyone in the network needs to be serving the most vulnerable. And we wanted to make sure that we have within the network a composition that includes those who are readily and have been reaching vulnerable populations as part of their business. But we also want to make sure that as we extend access across all provider groups, that everyone is engaged in supporting our equity goals. As you heard Marta say, we have the capacity to reach more than 6 million doses per week. That exceeds the goal of 4 million doses. And our challenge was to ensure that we were ready for the surge when that happens. And so clearly we are well positioned to do that. We do know now as this process iterates, and you heard Dr. Burke-Harris say that it's not enough to have equity in our thought bubble. We have to keep operationalizing it as we get more data, get more understanding. So while we have built a robust network, we also know that there are some providers, smaller providers that may be needed to get us through the next phase, and that process has begun. This slide shows that, as we would all suspect, federally qualified health centers are critical to achieving our equity goals, the work that they do in reaching the community. And we're very pleased with the progress that we've made in getting FQs on board in the network. You'll see the numbers here on the slide, and certainly we're pleased that we have 75% of FQs one way or another engaged or contracted, and those who are not are the reasons for that are explained on the slide. They may not be vaccinators, they may have a parent organization that does not choose to participate. But again, we're very grateful for the work of these organizations to help us achieve our equity goals. The next slide shows one example of a provider that has played a key role in extending our reach. OptumServe is an example of really wide distribution across the state through their 27 sites. They have 70% of their capacity is in the HPI first quartile. That gives us a lot of optionality, a lot of flexibility on rapidly standing up additional sites, driving for not only throughput, but to get to those remote areas, whether it's through mobile solutions, temporary pop-up sites, or other opportunities. So this is just an example of how we not only have built this robust network, but make sure that we've got a network that can be flexible, dialed up as we get more information on reaching the most vulnerable. Let's go to the next slide. And this is how, I really want to emphasize one of the points beyond allocation and network. One of the important points of the 5-point equity plan for the state is around data. And we are using the data as we get it to address challenges that may come along the way. So access clearly is important as we certainly celebrate the success that we heard Dr. Pond say and the progress that we're making, but understanding that there still is a long way to go. So as we get more data week to week, frankly, in some cases day to day, we are using that data to proactively identify and augment solutions where needed. So you'll see as we demonstrate here that if we get the data and we hear from the local health jurisdictions that we're partnering with, that there are special needs, whether it's from a transportation perspective or otherwise, we're able to quickly mobilize and make those adjustments. This would be a place where I'd want to remind everyone that we have local health jurisdictions, all with defined equity plans, and those are being actively worked on an ongoing basis so that as they get more data and they understand where there are gaps, we can really tap into the variety of resources that the state has provided or resources that the TPA can do to ensure that we maximize what we're trying to do there. The next slide just gives you a glimpse, and it's not easy to see, but it will give you a sense, another view of how we're using data to really measure our progress and then respond to the greatest need. So this is just a screen capture because I didn't trust the ability to try and show live, but what this does is it gives you a sense as to how we look at the results to know how is the network performing across each of the quartiles. And then we have a view here, and it's by county and local health jurisdiction, but we also have it more specifically by zip codes. We have other views that will also help us see the same data by provider. This is by age here. I know that you heard the comments earlier about the work that's being done to make sure we have accurate data on race and ethnicity. And so we also can see this data by gender. So this is by dose. We also have a view by recipient. So we're able to use this data on an ongoing basis to know where are the vaccines, where are they being allocated, who is being vaccinated, what's the time frame, and all of those things then enable us to be able to respond quickly so that, again, our equity goals are being actively worked on an ongoing basis. Now, the next slide will show another example of how we look at data. And this is really one where we'd love to have any help and insight from all of you. So if we could advance the slide, this shows you a snapshot of how the network is showing up from an extended coverage perspective. So when you look at this slide, you'll see in, by the color coding that at 51%, we have, a good portion of extended workday hours during the week for the HPI first quartile. But when you get to that lighter shade of pink, you'll see that we only have 30% extended weekday and weekend hours. That's the lowest amongst the quartiles. So by having this data, we're able to understand we have to do better there to create access. And it would be great if there are ideas and inputs that anyone in the group has. We also are actively working that and are in discussions right now with the TPA and with providers in the network to do what we can to get more extended hours, particularly in the weekend timeframe. The next slide just gives you, and you saw a sense of this earlier in Dr. Pan, but the bottom line is we're moving in the right direction. You'll see that the trend line at the bottom for vaccinating in the first quartile is going up. So we like that, we're closing the gap, but clearly we are not where we need to be. We absolutely agree with earlier comments about needing to increase to match the disease burden. The goal is to save more lives, and for those who are dying and being infected at higher rates, we got to get more vaccine there. So what we're doing is using the data, using the partnership at the local health jurisdiction level and with all stakeholders to really help us optimize how we can make good on that increased allocation and get more doses in arms. The next page gives you another example of sort of what we see as an important next step. As I mentioned, every local health jurisdiction has an equity plan. CDPH is doing a fantastic job working directly and in partnership with everyone in activating on those. CDPH will be launching, with support from the TPA, a pilot for some counties that are doing, that have lower vaccination rates in the first HPI quartile. And we'll be really doing some very targeted efforts there to understand what exactly are the levers that we can pull to see those numbers move up. As we do this pilot with sort of a handful of counties, we then are going to capture learnings. We'll be able to activate that more broadly across the system. So finally, I'm going to just go to the last slide there, and I want to go back to where we started when the first time the TPA talked to the group. This is what we set as expectations, why we felt the TPA was brought on board to partner with the state in this effort. And the bottom line is we are moving in the right direction together. You know, at the end of the day, our goal was to ensure that we had a robust network. And as we've described, we have that. The collective goal is to save more lives. And based upon what I think I heard the governor say recently, we're doing great as a state compared to everyone else in terms of case rate reduction. So that certainly is a very proud moment we should all celebrate. We also talked about improving and connecting the experience. And, you know, we certainly heard in the earliest of days, a lot of questions and concerns about MyTurn, but we've just seen phenomenal progress and improvement there. The number of appointments being set through MyTurn and the ability to use that central source of data to make quick decisions is really quite critical. We think about today's J&J News as an example, more than 500,000 appointments were able to be either canceled through clinics, redirected, or vaccine changed because it was all in the system. And MyTurn was able to quickly make adjustments to make it easier on our provider groups and the community. And there's lots of other examples around how we're using that data to help us in each one of these areas to both vaccinate Californians faster, to move those resources to diverse communities as they are needed, and certainly to make sure that we've got the data and reporting that helps us achieve the goals that Dr. Burke-Harris has for us all around safety, equity, and transparency. So I will end by saying we think that there's been great progress, yet there still is opportunity for us to learn and do more. If you have insight you want to share on both, you know, how to extend hours, particularly on the weekends, any thoughts there, as well as any other ways to better coordinate the equity tools that are available, whether they're coded clinics, et cetera. We welcome that input as well. We're gonna keep pushing and keep iterating every step of the way. And I want to just echo what Dr. Pond said. There is light at the end of the tunnel, but we just got to stay patient and stay diligent in these coming weeks to get us all the way to the other side. So thank you for the opportunity. My colleague, Peter Long, is here and certainly can help us. He's been a tremendous asset helping us connect the dots across the state and with our community partners. And he can be available to answer any questions as well.
Thank you so much, Kimberly. I apologize for missing your title. I think I just assume that every Black woman is a doctor. It's just like a bias that I have. But in any case, this is fantastic. I think what Kimberly pointed out and highlighted is how important it is for us to have data and metrics and goals and targets at every step of the way. And you know, even I will tell you, for me, I asked to have that slide included about the vaccine, about the clinic hour availability, because I really wanted to highlight the role of structural factors, right? We can designate vaccine allocation proportional to disease burden, but if in Q1 you have way fewer evening and weekend hours for working people, right? Then in Q4, like Q4 has the most evening and weekend hours. Those are real structural factors that are driving our ability to protect the health of the population. And so this is something that I really wanted to lift up to this group and really hear your best ideas and strategies about how we can incentivize vaccine providers to how we can bring the resources in line with the need.
Okay, thank you, Kimberly and Marta and Nadine for that. And let's hear from the rest of the group. Denny, maybe we can start with you because you had wanted to ask a question earlier. So Denny Chan, would you like to still make a comment? And then we'll go to Kieran and Dee.
Great, thanks, Bobby. Hi, everyone. Denny Chan, Justice and Aging. I want to give a big thank you to everyone at the state for really all the hard work for so many months now. It's been such a rewarding process to see all the progress we've been making. I originally wasn't actually going to say anything, but then Dr. Wasserman's comments got me going. So I wanted to lift up something that I've been mentioning in multiple meetings now, which is that this point about race and ethnicity data specifically for older adults. I've raised it at multiple meetings. I don't want to be the broken record here, but I guess I will. In March, at our March 17th meeting, this was raised in the chat box, and the CDPH answer, according to the documents that we got, was that we have that information and can share it at or before the next meeting. I've checked the state dashboard, and it is still only by age, and then by race, and then by gender. The little information we have at a county by county level, for example, in Orange County, indicates that Latino older adults 65 and up are 10% behind white older adults in terms of their vaccination rates. So I understand there's a big focus on HPI. I get it, I support it, I'm fully on board. Justice and Aging is signing every letter in support of using HPI as one of the powerful tools, but it is not by itself an adequate or sufficient measure. We need to have other data sources. I feel like I'm a little bit like preaching to the choir, but if part of what's holding up the process is that the data is not perfect, the story of race in this country is not perfect. So give us the data that you have, that counties have been collecting. We know it's been reporting, that some counties have been reporting out on this on a county by county level. My impression, and one of the reasons that we were switching to the TPA, was that we would get more timely and better data. And so I understand there are a lot of challenges, and I'm humbled by learning of those challenges. But as we think about tomorrow, we're opening up to everybody, and we put older adults back in the queue in January. And I still don't have any real concrete sense on a county by county level how older adults of color are faring, and only hypotheses. I mean, it feels a little bit like, I want to talk about the kids too, but I feel like we haven't finished the job that we were supposed to do. We haven't finished really making sure that the most at-risk folks, to Dr. Wasserman's point earlier, have gotten the vaccine. And so if there's anything, again, I implore the state, release the data, release what you have. I don't want perfect to be the enemy of the good here, as we are trying so hard to make sure that people get what they need. So I reiterate the call to get the data by race and ethnicity for older adults, specifically older adults of color. And thanks again for letting me speak, and thanks for all of your work.
Denny, I will say, and I will say on behalf of my my colleagues at CDPH, typically before we have these meetings, we've implemented a system where we run a check to make sure that we have responded to your questions, and try to make sure that we, in light of the ACIP meeting that was today and the news that came out yesterday about Johnson & Johnson, I think folks have been sprinting to gather a tremendous amount of data about the Johnson & Johnson vaccine situation. And so we did not follow up on that, but you have my commitment that you will have an answer before our next meeting. So I apologize.
Okay, thank you, Denny. Let's go on to Karen. Karen, don't forget to introduce yourself.
Sure, thanks, Bobby. Karen Savage, California Pan-Ethnic Health Network. Denny said some of what I was going to say, so I can be pretty quick. Just want to say on the race data, there was a reason to use the HPI first when we were thinking about reopening that made a lot of sense. HPI still made sense, but made a little bit less sense for allocation because that's going to be a much more targeted. And as we look at evaluating our progress, I think it's going to be really important that we don't overly rely on the HPI because we are, what at least I'm seeing when I look at the race data that's available is that it's not budging. As we've done a lot of things for equity, that overall statewide race data that's on the CDPH webpage really isn't budging in terms of the disparities. And so, I hope we're looking at that as well. And I'm wondering, I understand there's a lot of issues. The data is incomplete. We have nearly a third that's probably wrong that we're looking at. So I do get that. But I'm wondering sort of what the analysis is of why that data is not showing progress when the HPI data is, and what that means is happening. And I think, my assumption would be it really goes to the access barriers that I appreciate so much you talking about, Dr. Burke-Harris. And the only suggestion I have on that, in addition to what's been said already, is we're hearing a surprising amount concerns about cost. And I know we're all very clear the vaccine is free, but I hear that more than anything else right now about why people aren't getting vaccinated is they think they're going to have to pay. So I think as much as we can really lift that up in the messaging that we're doing, I think that's going to be really helpful because, people are used to nothing in healthcare is free, right? So I think it's taking a lot to make sure people understand, even if you don't have insurance, even if you're undocumented, the vaccine is free, right? So just want to really encourage us to push that message as much as possible.
Thanks, Karen. Dean?
Thank you, Bobby. I'm Dean Chalius with the California Association for Health Services at Home, serving home health and hospice providers. And I'd like to know how vaccinating homebound Californians is being addressed. We know that there's 2 million at least homebound seniors, and that number doesn't include those that are developmentally disabled, children that are homebound, temporarily homebound folks that are post-acute. And I'm just curious of how we're going to address that. We talk a lot about facilities and we talk a lot about transportation, but some folks can't get to facilities and can't leave their home to get on a shuttle bus. So thank you.
Sure, I'll briefly address that one. If my colleague Tricia from the Department of Public Health is on, I would invite her to jump in because she's more of an expert than I am. But we're working on a partnership with the Emergency Medical Services Authority to actually deploy ambulance strike teams, so EMT strike teams, to homebound individuals and their families to vaccinate. We're going to identify homebound individuals through a variety of different sources. So through health plans. So as health plans can look at their claims and identify individuals who are receiving vaccinations in a home setting. So that's one way. Through existing providers is another way. Also through local health jurisdictions are aware of where some homebound individuals live. That information is going to be given to each local health jurisdiction so that they can monitor in their community where the homebound individuals live, and they will coordinate with the ambulance strike teams. So it's through the mutual aid system that we have here in California. So that's the process that's going to be used. We're going to actually also have a toggle on the myturn.ca.gov website that an individual or a family member can click that basically says, I either have a transportation issue or I cannot leave my home. The language is still being worked out, exactly what it's going to say. And that will trigger actually a call center agent to reach out to the individual and walk through, is this an access, meaning a transportation issue, you cannot get to the appointment, or that you cannot leave your home, and then arrange for either transportation if that's the issue, or gather the information about the homebound individual and who else lives in the home that needs vaccination, and get that to the local health jurisdiction, who will then consolidate all of that information for the ambulance strike team.
Thank you. That's very helpful.
Thanks, Marta, and thank you, Dean, for raising up that question. I think we don't have any other questions at this point, so I think it's a great time, Nadine and Erica, to introduce Grace Lee, who's here with us again. She was at an earlier meeting, and talk about Johnson & Johnson.
Sure, I'm happy to introduce Grace as another PEDS ID colleague as well. Really appreciate working more with her on the Western State Scientific Group, and she's often willing to meet on short notice and come present to all of you. So I just really want to thank her for her service to the whole nation and to us as a state. As I mentioned, and as Dr. Burke-Harris mentioned, she's not only a member of the Advisory Committee on Immunization Practices, but she's sort of an expert in vaccine safety. And she, I think, co-chairs the Vaccine Safety Technical Subgroup, I think is the right title of the ACIP group, as well as Vaccine Safety Data Links. So if you have a moment even to highlight some of that work, Grace, that would be excellent as well. So thank you so much for joining us, and I'll let you take it away from here.
Sure, and if it's okay, I'll plan to share my screen. I just pulled together a high-level summary of the information from earlier today. Let me see if I can do this.
Yeah, it's fine, Grace. We'll take our slides down. There you go. Great.
Are you able to see that? Okay, perfect.
Yeah. Grace, if you could just speak up a teeny bit louder so everyone can hear you.
Sure, I spoke so much today, sorry.
I know. You've been through it, we know.
Terrific, thanks. This was all presented earlier today, and I just pulled out what I think are some of the key points for discussion today. So first, there was an introduction by Dr. Beth Bell, who chairs our COVID-19 vaccines work group, just providing the context that's needed about the adenovirus vector vaccines. There are two currently available. One is the Janssen/J&J vaccine. This is a one-dose vaccine that was approved for use on, actually recommended for use in the US on February 28th and distributed on March 2nd. It uses a human adenovirus 26 vector, and the EMA was also authorized for Europe, but doses have not yet been delivered or administered in Europe. In Europe, as many of you know, AstraZeneca, which is a 2-dose series, is a chimp adenovector vaccine, and that has been approved for use. It is awaiting EUA application in the US. What happened over the past week has been that AstraZeneca on April 7th, sorry, not AstraZeneca, the EMA and the MHRA, I believe, announced their concerns for these rare clotting events seen after AstraZeneca vaccination in the UK and Europe. And we also, at the same time, we're starting to query some of our data across the vaccine safety surveillance systems and found that some of the clinical syndromes and presentations were similar for these adenovirus vector vaccines, but lots of questions still remain. There's lots that still needs to be explored. In brief, the presentations that have been most notable have been these cerebral venous sinus thrombosis presentations, which is essentially clotting of the large vessels draining blood from the brain. In general, it tends to occur more frequently among younger adults, so 20 to 50 years of age, and among females. And some of the known risks are folks who are pregnant or on oral contraceptives or have other coagulation risks, whether genetic or acquired. And symptoms typically include headache, nausea, vomiting, or other neurologic symptoms. And this is different in that it is, persistent and worsening over time. We saw VAST, which is the vaccine safety technical subgroup that Dr. Pan mentioned, is a review of the data, did a review of the data on Monday, April 12th. So we saw that data from the VAERS reporting system through April 10th, and this was as of Monday. There were 3 cases following the Moderna vaccine. What's interesting is that these cases in general, you'll see the 6 cases below following the J&J vaccine, were associated with thrombocytopenia. And that's not typical for us. Typically, we don't see cases associated with thrombocytopenia. So the 3 Moderna cases that were observed were thought to be most likely due to background rates, since they were not associated with thrombocytopenia amongst 83 million doses administered. There were no cases reported in VAERS following the Pfizer-BioNTech vaccine with 95 million doses administered, and then 6 cases following the Janssen vaccine, but with thrombocytopenia in 6 million doses administered. And the characteristics of these cases were similar to what was reported out of Europe with thrombosis, so this clotting with thrombocytopenia, and elevated D-dimer and antibodies to platelet factor 4. You'll see here on the right that the age group, again, is in younger individuals. The cases that were reported into VAERS happened to be all female. There was one male in the clinical trial. And in Europe and the UK, there was also a female predominance. All the cases that were reported to date were in white individuals. We don't have race ethnicity from the AstraZeneca data, or we haven't seen that data. And then the timing of onset really has been within 2 weeks of receipt of vaccine. And I'll just note that, these are case reports that are coming into VAERS. One of the key pieces of information that we really need in order to support decision-making is information on the denominators to really understand what the risk estimates are and whether and how different they might be from baseline. So this particular vaccine safety technical subgroup, or VAST, discussed some of the key issues in an independent meeting and identified that this was clearly a rare but a serious adverse event, that risk factors are not yet well understood from the 6 cases. And if you go to the meeting minutes today from ACIP, you can see all of the details of the 6 cases. I didn't bring them here in interest of time. But there's not a clear pattern of these cases exactly. So we feel like there's more information that needs to be explored. The main concern and the reason that the pause happened was really because this is an unusual presentation. So there was concern for delayed recognition by healthcare providers in this cerebral venous sinus thrombosis with thrombocytopenia. And it's important because in order to be able to provide appropriate management in a timely way, in this case, the recommendation would be IVIG or anticoagulation with non-heparin-based therapy. So the typical treatment is heparin use. And in this case, actually, you would want to avoid heparin use if there was concern for this particular entity. And for these reasons, that pause was discussed yesterday. Just a few more key points. So there was a strong feeling that given this potential life-threatening adverse event was now emerging as a potential signal, even though there were only 6 cases reported, there was a strong feeling that we should provide this information to clinicians to enhance early recognition and appropriate treatment of individuals who develop thrombosis with thrombocytopenia following vaccination, and that we needed to have a further evaluation of the benefit-risk balance of using this vaccine in specific subgroups. And importantly, that timely and transparent communication with healthcare providers and the public would be crucial to maintain confidence in the vaccine program. So 24 hours after that meeting, this information was released, the Health Alert Network, to all our states and providers across the country, focused in on this particular unusual potential adverse event with recommendations for clinicians specifically to evaluate looking for this anti-platelet 4 antibody as would be performed for another similar type of syndrome, this heparin-induced thrombocytopenia, and to not treat with heparin unless this HIT testing is negative, and encouraging case reporting from our public health colleagues and from the public, especially for those who may have received the vaccine. So the next steps in brief are to ensure that we can continue to enhance case identification over the coming weeks through these notifications and increasing awareness amongst patients and providers. We are strongly encouraging all patients to report into vSafe. So the system has been available for a long time. We really, want individuals and to report in any potential adverse events, but that is one system that allows us to have patients report directly to the CDC. And then VAERS is a system that anyone can report into. It can be providers, patients, industry, anyone, and also strongly encouraging that any reports be reported into VAERS. And then we talked briefly about the what happens after a signal, a safety signal is identified. And what typically happens is we move into a signal refinement and a signal evaluation stage. The signal refinement stage really focuses on getting a better estimate of the risk and understanding the clinical characteristics. Signal evaluation is sort of formal epidemiologic studies that really try and get at whether or not there is causality. For the short term, we're really focused on making sure that we can review these findings in other vaccine safety surveillance systems. In the vaccine safety data link, there were 0 cases, but only approximately 130,000 individuals who received that vaccine in the system. And also to determine the risk of developing CVST with thrombocytopenia to inform risk mitigation strategies, as well as a benefit risk assessment. So in terms of what was reported today, prior to March 30th, there were about 3.5 million Janssen doses administered. And since March 30th to April 13th, when the safety pause was put into effect, there were 3.8 million doses administered. And the reason this is, and most of those events will develop within 6 to 13 days after vaccine receipt. So we wanted to make sure we enhanced awareness, enhanced surveillance, and continue to monitor safety as we're trying to understand and better define both the risks and the risk factors associated with this particular event. The prior ACIP vote on February 28th was that the Janssen COVID-19 vaccine was recommended for persons 18 years and older in the US under the EUA. I believe the FDA at the meeting mentioned that they would, put out information to providers and in the label to delineate this, to educate the public, sorry. And the questions that were put to ACIP today were whether or not we had enough information to make interim age or risk factor-based recommendations for use of the vaccine, and what recommendation did ACIP feel was appropriate today, given the current available information for use of the Janssen vaccine. And where we ended up was that we felt that additional information would be needed. We had 48 hours to review all available data and to have a discussion, but that data is evolving. And even in that 48 hours, I continue to see new details that are emerging because all of our vaccine safety colleagues are intensely working on the evaluation. I anticipate we'll continue to get more information over the next week. And Dr. Cohn from CDC, and she is the ACIP Secretariat, mentioned that we would plan to reconvene in another 7 to 10 days to discuss the emerging information so that we could have enough information to make an informed decision about recommendations for use of this vaccine. And with that, I'll stop sharing and happy to open it up for questions.
Great. Thank you, Grace, so much. It's been such a long day for you, and we really appreciate your presenting this data to everyone. Erica put in the chat the link to all the slides from ACIP, and we'll send out Grace's digest and the full deck after the meeting for all of you. So I think this would be a great time for anyone who has questions for Grace or Erica about the Johnson & Johnson situation and what the next steps might be. Okay, Sylvia, let's start with you, and please introduce yourself.
Hi, I'm Sylvia Healy with Disability Rights Education and Defense Fund. Thank you, Dr. Lee. I appreciate your explanation and your clarity. I think I'm just trying to think through some of this, and I appreciate all the difficulties of it. You mentioned at the end of that there is an attempt to be looking at age-specific safety, and I think I've been thinking especially of how the Johnson & Johnson vaccine in particular offered potentially a faster, more efficient way of reaching those who needed house call vaccination, and maybe certain other specific groups of individuals who would benefit greatly from a one-shot dosage or from vaccines that don't need deep sub-zero temperatures. And I think especially of this population, of this sort of older population who may be living in the communities, isolated, who can't leave their homes, because I think it's a similar population to those who have been in nursing homes, who basically for a year didn't get informed choice. Frankly, they were forced to be isolated in their rooms for a year with very little choice about about how they rated their quality of life versus the length of their life. And now I think we're looking at a population who are isolated in their homes and able to get out for vaccination, and facing much of that sort of, someone has decided that the risk to their life is more important than the quality of their life to a certain degree. And I'm just trying to think through in the prioritization of the kinds of information you're getting, whether there is really a strong attempt to be thinking about the safety of administering this vaccine to those who are older, looking specifically maybe at groups of people with disabilities as well, who are unable to get out for vaccination, who need a house call vaccination, and logistically could benefit greatly from the Johnson & Johnson vaccine in particular. And I appreciate that there are additional issues of perception, equity, how,
Yes.
Who's willing to have the vaccine, et cetera.
Mm-hmm.
But I still think there is something to be said for seeing how the safety of this vaccine for a particular group of that can't leave their homes.
Yeah, I really appreciate your comments, and it's actually really helpful for me to hear. And I thank you so much for inviting me today and for just letting me hear your feedback on this issue. Certainly, this vaccine offers many unique advantages, and I think that on the call today, maybe I'll just reflect on the call, which was that it's a combination of population benefit risk balance and individual benefit risk balance. And I think that the goal is to ensure that we can, wherever possible, mitigate the risks. So in some ways, it's not analogous exactly, but anaphylaxis is a known risk associated with vaccination. And we spent a lot of time initially in the initial weeks of the vaccination program ensuring that we could recognize that the risk exists and mitigate those risks as much as possible. And I think, as with any medical product or anything that we're doing, even like the risks of travel or the risks of, going into the community for some individuals, we have to balance all of those risks holistically. And what I would say is that it's really important for us to ensure that we can via ACIP, make recommendations that support population level risk mitigation wherever we can. Number two, that we support individual level benefit risk assessment by educating the public and by educating providers about how to ensure that we have early recognition and appropriate and timely management. And I think those are the strategies we can put together in place for what needs to happen. Now, what the decision will be, I don't know, but I do think that all of the comments that you made are extremely important because I think that this vaccine has been found to be efficacious. Not only did the question of equity come up in the US, but also internationally, globally, in that many countries still are awaiting access to vaccines. And so I think it's really important, and we're going to continue to basically, our goal is to decrease our uncertainty around what those risk estimates are. I think it was really difficult today because we're talking about 6 cases, and we need to be able to make sure that we have a good quantitative understanding of both the benefits and the risks in context in order to be able to make an informed decision. So my hope is that it won't take too long for us to ensure that we have reasonably robust information available on this. But we literally have had 48 hours, and I would say I'm still processing all the information as we go too. So thank you.
Thank you, Sylvia. I think that gave all of us a lot to think about in terms of the issue that you posed. Amanda, let's go to you, and then let's go to Deborah. Don't forget to introduce yourself.
Thanks, Bobby. Amanda McAllister-Wallner, she, her, hers with the California LGBTQ Health and Human Services Network. One thing that I haven't heard about, and I'm sure that you don't have an answer to, but just want to flag for, as you all are looking into this, is how trans folks may be affected, and what type of risk they may experience. We know that trans women who are taking estrogen, or other hormones are at increased blood clot risk, and also trans men who are on testosterone and other hormones can have increased risk of hypothysemia and thickening of the blood and other things that put them at higher risks of stroke, heart disease, and like other related illnesses. And so I expect that I will be getting questions about that from folks in LGBTQ communities, and I would love to be able to give them an answer about, what is the safety? What are, is it similar? What should folks be looking out for? And I think, we've been really trying to encourage folks to get vaccinated, make sure that we're getting good information out there, instilling confidence about the safety and effectiveness of these vaccines. And so just want to get out ahead of some of those potential concerns as much as possible.
Thank you. Yes, I mean, I think that we're also wanting to try and take a deeper dive to get some of that information, again, to understand if there are risk factors associated with a higher risk of this potential adverse event. That could really help us in terms of thinking about how to advise individual benefit risk balance. And so we will also be asking the same questions, but I appreciate your comment and your thoughtfulness about it.
Thank you.
Thanks, Amanda. Deborah.
Yeah, so Deborah Shade from the California School Board Association. I guess and thank you, Dr. Lee. I can't believe you're here. It was a long day. But I did want to ask you what you see the outcome. I mean, do you see recommendations that would say for the J&J vaccine in the US, if you're this age, you're this gender, this ethnicity, it's not recommended? That kind of specificity, or are you just trying to weigh the risk benefit and give sort of what type of care, response you would have if you see somebody with that type of reaction? So thank you.
So I can't really predict in terms of what I would say is there's supposed to be another ACIP meeting soon. So I think we'll get at specifically the questions around this. And I think the challenge today was, we have 6 cases, and I will say one of those cases actually did have oral contraceptive use, but other than those 6 cases, and then the other reports coming out of Europe and the UK, of which, we're able to see the summarized reports, but we haven't, reviewed the data directly. I think that it's really hard for us to be able to make an informed evidence-based decision on 6 cases. So as the data evolve and as we continue to learn more, my hope is that we will be able to, again, refine the information that, and we'll still be, to be fair, we're going to be stuck with uncertain information, but I still want us to have a little bit more clarity around the risks and the risk factors as much as is possible. Again, because I do feel like our purpose is to ensure that we are protecting public health and safeguarding the safety and the benefit risk balance really of vaccination. It's really critical to our vaccination program. We want to make sure we're enhancing confidence. I know that some people will feel like the safety pause that was put out by CDC and FDA was too soon. Some people will say it's not enough. I'm pretty sure no one's happy with with this information, but I think what we just have to do is work with what we have right now, move it forward. And the role of ACIP is to review all of the data and make the best evidence-based decision possible. We often do it under huge degrees of uncertainty, but I think for today, we just needed more information.
Thanks, Grace. Erica, is there anything you want to add now that Grace has reviewed the ACIP discussion about how our supply, or reinforce how our supply will be affected over the next few weeks? Anything more you want to say?
I mean, I think I could just recap a little bit of what I just sort of mentioned before, which is we already had anticipated decreased J&J because of the manufacturing issues that had come about. And then, it has varied from in the past from, when you look at all of our doses cumulatively, only about 4 or 5%. I think when you look at the federal allocations as well in the state, it's been as high as 6 to 7%. And I think there was hope that it could be more moving forward as far as expanding. But I do think, as I also kind of just alluded to earlier, but I think we are lucky in the United States that we do have a lot of other options as far as volume of Moderna and Pfizer vaccines. So I think it's definitely, it's definitely a disappointment, right? That as we're all talking about, there are a lot of really great aspects of this vaccine specifically. And so we look forward to, to hearing, more about the overall assessment about is this safe or safer in certain populations, and how do we kind of do exactly what Grace is outlining as far as, thinking about that population risk and then individual risk and informed consent around this. But again, thankfully, and it's just so much easier, of course, to be the one and done. But I think we do have other options, which again, we're grateful. There are some other countries that are really challenged. This is one of the analogous vaccine that may or may not be related, but they don't have a lot of other options, and they're experiencing deaths from the disease itself. So I think this is yet another really challenging broad decisions for all of us that this other twist in our tunnel turn that I was mentioning earlier. So yeah, we will stay tuned. And I can't remember if I already said, so this evening we'll get a little more of a recap again. Poor Grace will be really tired of talking about this because we're going to be meeting at least briefly later this evening with the rest of the Western State Scientific Safety Group. And then have a more kind of California specific follow-up tomorrow. But really grateful again to Grace for her willingness to come here after she's probably also been reviewing all this data over the last 48 hours as well, in addition to being in a lot of long meetings. So thank you very much.
Okay, maybe we could have a round of applause for Grace and her stamina, because she has another meeting with all of us tonight for the Western States Scientific Group. Grace, thank you so much. And I think Nadine and Erica, we're ready to begin to close the meeting.
Thank you so much, Bobby. Thank you, Dr. Lee, for joining us. I did want to say in response to, I think it was Amanda's comment or question in regards to the demographics. I think that in listening to the ACIP meeting today, one thing that I heard that I thought might be of interest to this group was a little bit about the demographics of the 6 out of 6.8 million individuals who had this rare but serious event, and that was that they were all women, and that the age range was between 20 and 50 years old. And I believe that they reported racial data on 5 out of the 6, and they were all Caucasian, I believe. But we don't have, but again, and as Dr. Lee mentioned, one patient was using oral contraceptives. So that's our data for here in the US. And I think that one of the things that, as Dr. Lee mentioned, as they're going through their process, comparing our data on Johnson & Johnson, looking at potentially the data for AstraZeneca, given that also is a vaccine that uses the same vector, which is the adenovirus vector, to understand if there is any relationship there and fully explore that, given that there were similar clotting events that were also seen with the AstraZeneca vaccine in Europe. And so I just wanted to share that information because I felt like that was something that would be helpful to this body. So I want to thank all of our presenters and all of our members today for another wonderful and robust discussion. As I was doing my best to keep up with some of the comments and the questions in the chat, but clearly because of this emergent issue, there were some things on our agenda that we had anticipated for today that got bumped so that we could bring you the latest information and that we could make sure to have time for Dr. Lee to be able to present to you all today. And so we will have more information at future meetings regarding some of our outreach and communication, and particularly connection to how we're looking at supporting and vaccinations for our unhoused population. And so we can look forward to that. I want to give an opportunity for, so I want to say that if any of you all, again, have suggestions for us or for the TPA on strategies that to improve our operationalization of equity. We took away the importance of data by both age and race. And we're taking away information. We're taking away some of the strategies that you all share today, but please continue to send those on to Bobby. You guys have done a wonderful job of sending resources in between meetings or strategies or suggestions. And in addition, we will share with you some information that we had prepared to share with you all about some of our outreach and community engagement efforts, as we recognize that equity is not about allocation alone, as was lifted up, but really is a multi-tiered, multi-pronged strategy that has to be deployed and very thoughtfully and followed up and continually driven towards. So you all will receive those materials after this meeting. Bobby will send that out. And I want to give an opportunity for Dr. Pond to share any additional words.
Thank you. Similarly, want to again thank Dr. Lee for coming and thank all of you for the ongoing constructive dialogue. I think, as mentioned, we've come a long way. We can always continue to get better. I think data specifically, as the state epidemiologist, feeling that my role that the data is really important has been, I think, one of the biggest challenges actually for this pandemic. And I think another illustration of, along with kind of this pandemic magnifying disparities, in our by race and by sort of poverty and other things. I think looking at the I just have to put on a little bit of my soapbox on public health, right? Like we have been using faxes for, much longer than everyone else. We've not had investments in our infrastructure and our information technology and our workforce. And so that was really magnified in this pandemic. And that is, so just, thanks for your patience with us. We absolutely, our heart is in exactly the same place, and we really appreciate the pushing and the dialogue. And actually it does make us better, and it helps push for the resources to help us too, to do what we all have as a collective goal, I think, which is to really serve the entire population and also lift up for equity. And then I think, today again, really highlighted the transparency and safety. And I think the other part is 6 individuals is not much as far as data. So we're going to have to, as a nation and as a state, going to be making yet another really tough decision. So we appreciate the dialogue around that. And I think just it is always weighing benefits and risks. So thank you for your partnership in that and for patience with us, and really looking forward to the next meeting and continue to work with all of you. Thank you.
And I want to, before we adjourn, I just want to remember to highlight and remind all of us about the bi-directional nature of the partnership and information exchange in this gathering. So we've shared a lot of information with you today about our, where we are with our implementation and allocation. We've shared with you about the Johnson & Johnson information and about our equity strategies. And I hope I will ask you to carry that forward as you all, as trusted messengers to the communities that you represent, to reach out and share this information, share the information about what's happening with Johnson & Johnson, share the information about what's happening with our equity strategy, and really be a conduit to lift up the voices of the communities that you all represent back to us, back to the state, so that we can continue to do this work on behalf of the people of California to the best of our ability. With that, our next meeting is going to, will be on May 12th from 3 to 5 p.m. We will send out the agenda ahead of time. As always, we invite the public to make comment, and the public can do that at COVID-19 vaccine outreach at cdph.ca.gov. And in the meantime, thank you again so much for your continued hard work and partnership on this effort. And we look forward to seeing you at the next meeting. Be well.
Thanks, everybody.